So, I was working this night shift, must have been 3, maybe 4 years ago, and we had this patient roll into the bay, totally convinced they were having a massive stroke because the entire right side of their face was just completely sagged, drooling, couldn't even blink the right eye. But the weird thing was, they could move both arms, walk totally fine, talking was okay besides the drool. It turned out to be Bell's palsy, not a stroke at all. But man, that initial visual, it really sticks with you.
Oh, yeah. It's terrifying for them because you see a drooping mouth and immediately your mind goes to, brain attack, stroke. But with Bell's, it's actually, it's localized. It's a disruption of the motor branches of cranial nerve 7, the facial nerve. Just on one side, acute peripheral facial paresis. But, Caitlin, you mentioned they could walk. That's the key, right? It's just CN7.
Exactly, Derek. And as educators, we really have to train our students to recognize that distinction immediately. With Bell's palsy, you're looking at that isolated facial nerve disruption. Drooping, drooling, can't close the eye, maybe some pain behind the ear. But if you start seeing weakness that, say, starts in the feet and literally climbs upward, that is a whole different beast. That is Guillain-Barré syndrome, and that is a true medical emergency.
Right? Because Guillain-Barré is this rapidly progressing, potentially fatal polyneuropathy. It's attacking the myelin sheath in the peripheral nervous system. So instead of just one nerve in the face, you've got this systemic demyelinating process. I mean, Bell's palsy, most people start getting better in 2 weeks? Fully recovered in 6 months. But GBS? That weakness climbs until it hits the diaphragm, and then suddenly, you're looking at respiratory failure. During the COVID pandemic, there was an increase of GBS cases because the respiratory infection was a trigger. Studies showed that patients with COVID are 6 times more likely to develop GBS.
That's a huge contrast. So, if we rederive this simply for the bedside, if the problem is just one facial nerve, we're thinking Bell's palsy. We protect the eye, maybe give some oral steroids. But if the problem is widespread, ascending weakness, that's GBS, and we need to watch that airway like a hawk.
Now, when we move from the peripheral nerves to the central nervous system, specifically the spinal cord, the entire paradigm of care shifts. Spinal cord injury, or SCI, is overwhelmingly traumatic. We're talking 38% from motor vehicle collisions, followed closely by falls at about 30.5%, then violence in sports. And the immediate management at the scene is everything.
That reminds me of a patient we had in the ER in El Paso. Young guy, fell from a high deer stand. The struggle to keep him fully, and I mean fully, immobilized during transfers, log rolling him, getting the x-rays. C7 and T1 are so hard to visualize on standard cervical films. It takes a whole team just to move one person safely without extending any potential cord damage. The anxiety in the room is palpable because one wrong tilt could mean permanent paralysis.
Oh, absolutely. The pressure is intense. And what makes it so tricky in those early hours is this thing called spinal shock. Students always mix up spinal shock and neurogenic shock, but they are totally different. Spinal shock is this temporary electrical silence, basically. You lose all deep tendon reflexes, sphincter reflexes, sensation, and you get flaccid paralysis below the injury. It can last days to weeks, and it completely masks what the actual permanent neurologic damage is going to be.
Yes! I tell my students all the time, do not confuse the two. Spinal shock is about reflexes and flaccidity. Neurogenic shock, on the other hand, is a hemodynamic crisis. It happens with injuries at T6 or higher because you lose sympathetic nervous system tone. Without that sympathetic drive, you get massive peripheral vasodilation and venous pooling. And what are the classic signs, Derek?
Right. It's that classic duo, hypotension. But instead of the tachycardia you usually see in hemorrhagic shock, you get bradycardia. The heart rate slows down because of the unopposed vagal response. It's really counterintuitive for new nurses who expect the heart to pump faster when blood pressure drops. But here, the brakes are on, and there's no gas pedal.
So, when we classify these injuries, we look at the mechanism. Is it flexion, like a head-on car crash? Hyperextension, like falling forward onto your chin? Or vertical compression, like diving into a shallow pool? And then we look at whether it's complete or incomplete. Complete is just what it sounds like. total loss of motor and sensory function below that level. But incomplete? That's where you get these really specific, almost bizarre syndromes.
Oh, the incomplete syndromes are classic test questions, but they're also real clinical presentations. You've got central cord syndrome, anterior cord, Brown-Séquard, where one side of the body loses motor function and the other side loses pain and temperature sensation. Then there's cauda equina and conus medullaris. It all depends on which nerve tracts are spared.
It's like a map. And if that injury is above T6, like we mentioned, the sympathetic nervous system is essentially cut off from the brain. So, you're not just dealing with paralyzed legs or arms, you're dealing with poikilothermia, where the body can't regulate its temperature and just takes on the room's temperature. They can't sweat or shiver below the injury. You are literally managing their internal climate for them.
Okay, so let's walk through the immediate nursing moves. If you have a high cervical injury, say C3 to C5, what's the first thing you're thinking about? It's the phrenic nerve. They lose diaphragmatic function. If they're above C3, they'll arrest within minutes without intubation. So airway and ventilation are absolute priorities. But then we have to look at the gut and the bladder.
Yes, the autonomic shutdown is massive. Within the first 48 to 72 hours, the GI tract basically goes on strike. Paralytic ileus is incredibly common, so you need a nasogastric tube to decompress the stomach, and they need aggressive nutritional support because their metabolism skyrockets to break down protein for repair. And the bladder? It's totally flaccid. If you don't manage urinary retention immediately, that urine backs up, causes reflux into the kidneys, and can lead to acute renal failure.
So if we boil that down, the clinical picture is lungs, bladder, bowel, and blood pressure. In that order. If you're keeping those four stable, you're preventing the most immediate life-threatening complications of an acute spinal cord injury.
But then, once they get past that acute, flaccid spinal shock phase, if their injury is at T6 or higher, there is this massive ticking time bomb we have to talk about: autonomic dysreflexia. I remember a new nurse who was about to give a suppository for a bowel program, and suddenly the patient's face went bright red. They started sweating profusely above the injury and complained of this hammering, splitting headache. Their blood pressure was like 210 over 110.
Oh, that is a textbook autonomic dysreflexia crisis. It's a massive, uncompensated cardiovascular reaction. What happens is some noxious stimulus below the level of injury, most commonly a distended bladder or a blocked urinary catheter or a full rectum, sends sensory signals up the cord. But the signal can't get past the block at T6. So the sympathetic system goes wild below the injury, vasoconstricting everything, driving the blood pressure through the roof.
And the brain tries to fix it by slowing the heart rate down, which is why you get bradycardia and vasodilation, but only above the level of injury. That's why they get flushed and sweaty in the face, but cold and pale below. Caitlin, what did that nurse do?
Well, thank goodness her preceptor grabbed her, immediately sat the patient upright to 45 degrees to lower the blood pressure using gravity, and then they checked the Foley bag. Sure enough, the tubing was kinked. As soon as they unkinked it and drained the bladder, the blood pressure plummeted back to normal. But if you don't act fast, they can stroke out right there at the bedside.
Exactly. Elevate the head of bed, find the cause, alleviate the stimulus, and notify the provider. Even simple things like suctioning or turning can trigger autonomic instability because of that unopposed vagal response. We have to be so gentle and intentional with every single intervention.
It really shows how delicate these pathways are. Whether it's managing Bell's palsy with facial exercises, protecting their cornea with patches and drops because they can't blink, or monitoring a GBS patient's vital capacity to make sure they aren't losing their ability to breathe. It's all about anticipating where the nerve pathway is failing.
Totally. It's that pattern recognition. If you can map the symptoms to the anatomy, you're never just guessing at the bedside.
And that's the core of great neuronursing. Until next time, keep studying and using your critical thinking skills to build that knowledge.